The introductory resources in this series include a tip sheet for states on incorporating D-SNPs into Medicaid quality improvement activities that we have released in October of 2023, and a webinar on improving quality and performance in D-SNPs that we released shortly thereafter. These resources are available on the ICRC website at integratedcareresourcecenter.com. Slide 4, please. The introductory resources provide foundational information for states, such as quality oversight of coordination-only D-SNPs versus quality oversight of D-SNPs that cover Medicaid benefits. The resources also discuss the quality improvement lifecycle, including how to incorporate D-SNPs into Medicaid quality improvement activities, such as quality strategies, Medicaid quality assessment, and performance improvement programs, and external quality review. The resources also explain what Medicare resources are available to states to monitor D-SNPs, including the level at which they provide information, such as the plan, contract, and sponsor levels. Finally, the resources explain the advantages of using the D-SNP-only contract option to facilitate use of Medicare resources to oversee D-SNPs, which we'll also briefly cover later in this webinar. This webinar builds on these introductory materials and specifically will dive into long-term services and supports, or LTSS, and behavioral health services and provide tips to states on how to oversee and improve these services for D-SNP enrollees. Slide 5, please. For today's webinar, we will cover the following. First, I will introduce the presenters for today's webinar. Next, we will discuss the importance of improving the quality of LTSS and behavioral health services for dually eligible individuals. And then we will provide a brief refresher on the quality improvement lifecycle. Following that, we will discuss key steps in improving LTSS and behavioral health services for D-SNP enrollees. And finally, we will wrap up with some question and answers. Slide 6, please. During today's webinar, we will hear from 4 ICRC presenters from Mathematica. In addition to me, Maddie Spearing, you will also hear from Elizabeth Boystack, Malia Valentine, and Emily Costello. Slide 7, please. We would also like to thank our 2 ICRC subject matter experts from Mathematica, Ryan Stringer and Aaron Weirlock-Money. With those brief introductions taken care of, I will now hand it off to Elizabeth. Next slide, please.
Thanks, Maddie. I'm Elizabeth Boystack with ICRC. I will describe the importance of improving the quality of LTSS and behavioral health services for dually eligible individuals. Next slide, please. Slide 9. First, I will describe LTSS needs and coverage for dually eligible individuals. More than 40% of dually eligible individuals use LTSS, and they are nearly 4 times more likely to need institutional LTSS than people who are only eligible for Medicaid. When it comes to coverage, Medicare covers skilled nursing facility services, but Medicaid plays a large role in other LTSS services. Medicaid, for example, is the sole payer for institutional LTSS and home and community-based services, which are also referred to as HCBS. At the bottom of the slide, we listed 2 ICRC resources about Medicaid and Medicare coverage of LTSS. The first is an overview of Medicare and Medicaid nursing facility benefits and the options for improving coordination and quality. The second resource provides an introduction to Medicare benefits and the roles of Medicare and Medicaid in serving dually eligible individuals. These resources are both located on the ICRC website. Slide 10, please. Next, we will describe the behavioral health needs and coverage for dually eligible individuals. A higher proportion of dually eligible individuals have behavioral health needs than the general Medicaid population. For example, half of full benefit dually eligible individuals report having a mental health condition, compared to 29% of Medicaid-only enrollees. For coverage of behavioral health services, Medicaid covers those services that fall within mandatory Medicaid benefit categories, and states can cover additional services through state plans or waivers such as state plan amendments and 1115 demonstrations. In 2024, CMS expanded Medicare coverage of behavioral health services, such as new substance use disorder or SUD services. Like the previous slide on LTSS coverage, we listed two ICRC resources that include information about Medicaid and Medicare coverage of behavioral health benefits. The first covers coordination of Medicare and Medicaid behavioral health benefits, and the second is another resource in this quality oversight and improvement series that Maddie described earlier on incorporating D-SNPs into Medicaid quality improvement activities. So I'll now pass it back to Maddie for a refresher on the quality improvement life cycle. Slide 11, please.
Thanks, Elizabeth. Now, I'm going to provide a brief refresher on the quality improvement life cycle, which we have detailed in earlier resources in this series. Slide 12, please. So the first step in the quality improvement life cycle is to identify quality improvement opportunities. This involves using Medicaid and Medicare quality measure results to identify quality improvement opportunities. Some example measure sources include the Healthcare Effectiveness Data and Information Set, or HEDIS measures, and the Special Needs Plan HEDIS measures, also known as SNP HEDIS measures. Other example measure sources include the Medicaid Adult Core Set measures, measures developed by states, and measures developed by others, such as research entities. States that are interested in using adult core set measures should note that although dually eligible individuals are exempt from mandatory adult core set reporting through 2026, CMS expects to phase them in. Although dually eligible individuals are currently exempt from mandatory reporting, some states have already started to collect and report data on this population. We included more information on core set reporting at the bottom of this slide. In addition, states interested in using their own measures or measures developed by other states will need to consider the capabilities of their existing data collection and organization infrastructure, their data sharing systems, and their capacity for developing and maintaining measure specifications. After gathering measure results, states should compare plan data to data from other plans, compare plans to state or national performance data, or compare plans to specific benchmark targets. If plans vary considerably in their performance on a measure, that may be a signal to an opportunity to improve the performance of the plans with lower scores. Slide 13, please. After using measure results to identify quality improvement opportunities, the second step in the quality improvement life cycle is setting measurable goals and objectives. Goals are high-level managed care performance aims that provide direction for the state. Objectives are measurable steps towards meeting the state's goals and typically include quality measures. For example, a state may set a goal to improve coordination during care transitions with an objective to increase follow-up rates after discharge from hospitals for dually eligible enrollees with behavioral health needs. Goals and objectives can be specific to D-SNPs, or they can apply to any combination of a state's Medicaid managed care programs. For example, a state may add D-SNPs to its existing behavioral health quality improvement goals that apply to all the state's Medicaid managed care programs. Slide 14, please. This next step in the quality improvement life cycle is implementing quality improvement tools. There are a number of Medicaid and Medicare quality improvement tools available for states to use when working to drive performance improvement. The first example highlighted on this slide is Quality Assessment and Performance Improvement, or QAPI programs. QAPI programs include performance measures, performance targets, and performance improvement projects, also known as PIPs, that aim to improve the quality of care delivered to Medicaid enrollees. States can also use Medicare quality improvement tools to drive quality improvement. These tools include Medicare Advantage quality improvement programs, as well as Medicare Advantage chronic care improvement programs, also known as CCIPs. Chronic care improvement programs promote effective chronic disease management and the improvement of care and health outcomes for enrollees with chronic conditions. In addition, states can use D-SNP models of care, also known as MOCs, to peruse and pursue their quality improvement goals. States can use their state Medicaid agency contracts or SMACs to require D-SNPs to include state-specific goals, measures, and projects in their quality improvement programs, chronic care improvement programs, and models of care. Slide 15, please. This last step in the quality improvement life cycle is to periodically evaluate statewide and plan level progress towards quality improvement goals and objectives. States can implement, review, and customize several Medicaid evaluation tools, including Medicaid Managed Care External Quality Review, or EQR, which includes specific mandatory and optional activities and is implemented through formal EQR protocols. Medicaid managed care quality strategy evaluations are less structured than the formal evaluation process of EQR. These involve assessing whether the state is meeting its goals and objectives or if further interventions are needed. While on the Medicare side, Medicare Advantage plans, including D-SNPs, are required to report the status of their chronic care improvement programs to CMS annually through the Health Plan Management System, or HPMS. States can use their SMACs to require D-SNPs to report this information to the state as well. Similarly, states can require D-SNPs to submit their models of care evaluations to the state. Slide 16, please. As described earlier, states can leverage their SMACs to pursue their quality improvement goals. For example, states can use their SMACs to require D-SNPs to submit quality measure data and results to the state, implement quality improvement tools, and undergo evaluations. Sample contract language is available in the ICRC resources linked on this slide. Slide 17, please. Some Medicare resources, like Medicare Advantage HEDIS measures, are only available at the Medicare Advantage contract level. Because Medicare Advantage contracts can include multiple plans operating across states, this can dilute the state's ability to leverage these resources for monitoring individual D-SNPs. In the spring of 2022, CMS finalized a new contracting opportunity for states, through which states can require D-SNPs that operate with exclusively aligned enrollment to operate within what CMS calls D-SNP-only contracts. Through this opportunity, a state can require its D-SNPs to establish contracts with CMS that only include one or more D-SNPs within the state. While states exercise this D-SNP-only contract option, it enables reporting of contract level resources to be specific to the D-SNPs that are offered by a particular Medicare Advantage sponsor within a particular state. Some examples of these contract level resources include Medicare Advantage, HEDIS measures, and the Medicare Star Rating system. CMS issued sub-regulatory guidance for states in August of 2022 regarding key considerations and processes for pursuing this opportunity. If you're interested in this opportunity, feel free to reach out to CMS and ICRC to discuss this process. You can also find additional information about D-SNP-only contracts through the links on this slide. And now I'll pass it off to Malia. Slide 18, please.
Thanks, Maddie. Next, we will discuss how states can improve LTSS quality for D-SNP enrollees. Slide 19, please. The first step is to identify LTSS quality improvement opportunities. There are several resources available to states to identify these opportunities, such as the HCBS Consumer Assessment of Healthcare Provider and System Survey, or CAHPS, and the Medicaid LTSS Quality Measure Set. The HCBS CAHPS survey captures adult enrollees' experience with LTSS, including LTSS provided through managed care. The survey helps to measure how well staff listen and communicate, unmet needs, physical safety, global ratings, as well as other concepts. Like Medicare Advantage HEDIS measures, CAHPS measures are reported at the contract level, so states can use the D-SNP only contract option to make these measures more useful to them. In addition, the Medicaid LTSS quality measure set covers topics such as preventing falls, admission to a facility from the community, minimizing facility length of stay, and successful transition after long-term facility stays. A full list of measures is included in Appendix A. Slide 20, please. States can also use their SMACs to require D-SNPs to submit LTSS measure results and data. Indiana's SMAC, for example, requires D-SNPs to submit summary and patient-level HEDIS data and CAHPS reports to the state. Because HEDIS measures are reported at the contract level, and a D-SNP may be a part of a Medicare Advantage contract that includes additional plans operating in other states, the SMAC also requires D-SNPs to report certain HEDIS measures specifically for enrollees in Indiana, including measures related to care for older adults, transitions of care, and plan all-cause readmissions. Slide 21, please. This slide contains 4 examples of LTSS measures, all of which come from the Medicaid LTSS quality measure set. The first measure, Manage LTSS Comprehensive Assessment and Update, assesses the percent of LTSS enrollees with a documented comprehensive assessment. The next measure, Manage LTSS Comprehensive Person-Centered Plan and Update, assesses the percent of LTSS enrollees with a documented person-centered plan. The Manage LTSS Screening, Risk Assessment, and Plan of Care to Prevent Future Falls measure assesses the percent of LTSS enrollees with documented screening for history of falls, problems with balance or gait, or both. Finally, the Manage LTSS Shared Person-Centered Plan with Primary Care Provider measure assesses the percent of LTSS enrollees with a person-centered plan transmitted to their primary care provider. Slide 22, please. After gathering measure results, states should compare plan data to data from other plans, compare plans to state or national performance, or compare plans to specific benchmark targets. The example on this slide uses the measure hospitalization following discharge from a skilled nursing facility within 30 days, where a lower rate indicates better performance. In this case, we can see that D-SNPs A and B both have rates that are higher than the national average of 13%, and therefore there is an opportunity to improve performance on this measure. Slide 23, please. After identifying LTSS quality improvement opportunities, states can develop quality strategy goals and objectives that aim to improve plan and/or statewide performance on these opportunities. As Maddie explained earlier, goals are high-level aims designed to provide direction, while objectives are specific, measurable steps that often include performance measures. Some example LTSS goals include improving HCBS care for LTSS enrollees, reducing fall risk for nursing facility residents, and increasing coordination between LTSS and primary care providers. To make these LTSS goals actionable, states can pair each of them with one or more objectives, a measure, and a performance target. The measures could include the LTSS measures I mentioned in previous slides, or other measures identified in Appendix A. In the next few slides, I will walk through specific examples of goals and objectives with measures and performance targets. Slide 24, please. This slide contains an example LTSS goal and objective. After identifying a quality improvement opportunity using the hospitalization following discharge from a skilled nursing facility measure, the state could set a goal to increase access to HCBS coordination after hospitalization for enrollees with recent skilled nursing facility stays. An example objective includes increasing the percentage of recently hospitalized D-SNP enrollees who receive outreach from an LTSS coordinator within 60 days of hospitalization. To measure progress towards meeting the goal and objective, the state could measure the percent of enrollees who received follow-up outreach. States can apply this and similar goals and objectives to D-SNPs that are directly capitated to cover Medicaid LTSS benefits or D-SNPs affiliated Medicaid managed care plans. Slide 25, please. In this slide, we show an example LTSS related goal and objective from the District of Columbia's quality strategy. Under a goal to improve population health are objectives to increase the percentage of LTSS enrollees who receive an LTSS comprehensive plan assessment and update, an LTSS comprehensive care plan and update, and a reassessment and care plan update after discharge. The district also set an objective to increase HEDIS rates for many LTSS adjacent measures. And finally, the district measures the percent of LTSS enrollees who have a documented comprehensive assessment to help measure progress towards this goal and objectives. Slide 26, please. After the state develops LTSS goals and objectives, the state should implement quality improvement tools such as PIPs or requirements for D-SNP models of care with specific topics, aims, interventions, and performance measures that align with the associated goals and objectives. For example, a state may set a goal to reduce avoidable emergency department utilization among LTSS enrollees. To progress towards this goal, a state might implement a PIP that aims to reduce avoidable emergency department use among LTSS enrollees who had 3 or more emergency department visits in a quarter through 2 interventions. The first involves educational outreach for LTSS enrollees to reduce avoidable emergency department use and increase the use of emergency department alternatives. The second involves a program to facilitate increased coordination between primary care and HCBS providers aimed at reducing avoidable emergency department use. To evaluate the PIP, the state can measure the percent of LTSS enrollees with 3 or more emergency department visits in a quarter, which aligns with the measure included in the goal and objective. Slide 27, please. States can customize D-SNP involvement in LTSS Medicaid quality improvement tools based on the D-SNP's level of integration. For example, a coordination-only D-SNP that does not cover Medicaid LTSS would only be involved in a PIP if the PIP focuses on services where the D-SNP is the primary payer, such as skilled nursing facility care. On the other hand, a high D-SNP may cover Medicaid LTSS services. If the HIDE SNP covers LTSS, the SNP or its affiliated Medicaid managed care plan implements the PIP. Finally, a FIDE SNP is required to cover LTSS services, and therefore the FIDE SNP implements the PIP. Slide 28, please. This slide shows a PIP used by the District of Columbia that aims to reduce falls among enrollees. The district used 4 interventions, including discussing fall risk, managing fall risk, fall screening and risk assessment, and plans of care. To evaluate the PIP's performance, the district used the HEDIS fall risk management measure and the CMS LTSS screening, risk assessment, and plan of care to prevent future falls measure. Slide 29, please. In addition to implementing Medicaid PIPs, states can leverage their SMACs to require D-SNPs to focus their Medicare quality improvement tools to improve LTSS quality. For example, the Chronic Care Improvement Project on this slide aims to minimize facility length of stay for enrollees with LTSS needs, particularly those with dementia and spinal cord or traumatic brain injuries. The chronic care improvement project's interventions include enrollee and family support to minimize avoidable institutionalization, enrollee and family education on HCBS options for people with dementia, and coordination with inpatient and long-term care providers to minimize avoidable institutionalization and promote community transitions. This chronic care improvement project uses the Manage LTSS minimizing facility length of stay measure to assess performance. Slide 30, please. Finally, after using Medicaid and Medicare quality improvement tools to improve performance, states should evaluate statewide progress towards their goals and objectives. In this first example, prior to implementing an intervention to reduce or manage fall risk, the statewide baseline rate on this fall risk measure was 70%. After implementing quality improvement tools, the state improved performance on this measure to 80%, with additional room to improve. Furthermore, states can evaluate plan progress towards meeting the state goals and objectives. Similar to statewide performance, the D-SNPs in this example at the bottom of the slide improve their performance compared to their baseline rates, with room to improve towards their plan level performance goals. Slide 31, please. This slide shows an example of an EQR evaluation of an LTSS PIP. The PIP aimed to increase the percent of enrollees with LTSS needs who receive outreach from an LTSS coordinator within 90 days of enrollment. As shown in the table to the right, the percentage of enrollees who received outreach from an LTSS coordinator increased from a baseline rate of 79% to 83%. States can use this or similar methods to evaluate their LTSS PIPs. Next, I'll turn it over to Emily to discuss behavioral health quality improvement. Slide 32, please.
Thanks, Malia. Next, we will discuss how states can improve behavioral health quality for D-SNP enrollees. Slide 33, please. The first step is to identify behavioral health quality improvement opportunities. Like the LTSS resources that Malia described earlier, there are several resources available to states to identify these opportunities. For example, the Medicaid Adult Core Set contains measures covering topics such as antidepressant medication management, engagement in substance use disorder treatment, outpatient follow-up after hospitalization and emergency department visits, and diabetes care and screening for individuals with mental illness. As we described earlier, while it is not mandatory for states to include dually eligible individuals in their adult core set reporting, CMS expects to phase in dually eligible individuals into mandatory core set reporting, and some states already collect and report data for this population. Therefore, states can consider how they might use adult core set measures in their behavioral health quality improvement activities for dually eligible individuals. Additionally, D-SNPs are required to report SNP HEDIS measures to CMS. The SNP HEDIS measure set contains some of the same measures included in the Medicaid adult core set, including antidepressant medication management and follow-up after hospitalization for mental illness. Like with the LTSS quality measurement, states can require D-SNPs to submit SNP HEDIS measure data and results via their SMACs. Appendix A includes a comprehensive list of measures. Like LTSS quality improvement, when determining which sources to use to identify behavioral health quality improvement opportunities, it is important to consider the level at which the measure data is reported. For example, adult core set measures are generally reported at the state level and provide a high-level overview of performance across the state amongst all populations, including non-dually eligible enrollees. That said, because states gather adult core set data from individual plans, states can narrow in on individual plans and populations, such as D-SNPs and dually eligible individuals. As described earlier, SNP HEDIS measures are reported at the plan level, meaning that the results represent the performance of individual D-SNPs. Slide 34, please. This slide contains 4 examples of commonly reported behavioral health quality measures, all of which are HEDIS measures. These measures include antidepressant medication management, which assesses medication compliance for individuals newly prescribed antidepressant medication. Next, we have follow-up after hospitalization for mental illness, which assesses the rate of follow-up care with a mental health provider following a hospitalization for mental illness or intentional self-harm. Next is follow-up after emergency department visit for substance use, which assesses the rate of follow-up care after an emergency department visit with a primary diagnosis of SUD or drug overdose. Finally, we have initiation and engagement of substance use disorder treatment, which assesses if an individual diagnosed with SUD receives treatment within 14 days of diagnosis. Slide 35, please. After gathering behavioral health measure results, states can compare plan performance with other plans, statewide performance, and/or national performance. States may also consider comparing their statewide performance to other states' performance on a given measure, as well as to national performance. The example on this slide uses the measure follow-up after hospitalization for mental illness, where a higher rate indicates better performance. In this case, D-SNP-A and D-SNP-B have similar performance rates, but both rates are lower than the statewide Medicaid average and the SNP-HEDIS national average. Therefore, there is an opportunity to improve performance on this measure. Slide 36, please. After identifying behavioral health quality improvement opportunities, states can develop quality goals and objectives that aim to improve plan and/or statewide performance. As Maddie mentioned earlier, goals are high-level aims designed to provide direction, while objectives are specific, measurable steps that often include performance measures. Some example behavioral health goals include reducing opioid abuse, improving medication adherence for individuals with serious mental illness, improving management of comorbid physical health conditions for individuals with serious mental illness, or improving care coordination between physical and behavioral health care. To make these behavioral health goals actionable, states can pair each of them with one or more objectives, measures, and performance targets. The measures could include behavioral health measures I mentioned in previous slides or other measures identified in Appendix A. In the next few slides, I will walk through specific examples of goals and objectives with measures and performance targets. For additional examples of behavioral health goals and objectives, we recommend reviewing the Substance Abuse and Mental Health Service Administration, or SAMHSA's, 2023 to 2026 strategic plan, which contains national level goals and objectives that could be adapted for state use. Slide 37, please. This slide contains an example behavioral health goal and objective. After identifying a quality improvement opportunity using the follow-up after hospitalization for mental illness measure, the state could set a goal to improve access to outpatient mental health care with an objective to increase the rate of follow-up after hospitalization by 5% within 3 years. As with the LTSS goals and objectives that Malia described, states can apply this and similar goals and objectives to D-SNPs that are directly capitated to cover Medicaid behavioral health benefits or to D-SNPs affiliated Medicaid managed care plans. Slide 38, please. In this slide, we show an example behavioral health related goal and objective from the District of Columbia's quality strategy. Under a goal to improve management of chronic conditions, the district has 2 objectives to increase the 7 and 30-day follow-up rates after emergency department visits for mental illness. Both of these objectives use the adult core set measure follow-up after emergency department visit for mental illness to measure progress. Slide 39, please. After the state develops behavioral health goals and objectives, step 3 involves implementing quality improvement tools such as PIPs or requirements for D-SNP chronic care improvement programs or models of care. As both Maddie and Malia mentioned earlier, there are multiple Medicaid and Medicare quality improvement tools that states can use to pursue their behavioral health quality improvement goals. For example, a state may set a goal to improve access to outpatient mental health care. To progress towards this goal, a state may implement a PIP that aims to increase the rate of follow-up after hospitalization for mental illness and use of outpatient behavioral health services through two interventions. The first is targeted enrollee outreach to encourage engagement with follow-up and outpatient services, and the second is a program to support collaboration between inpatient and outpatient facilities. Also, the measure used for this PIP is the same measure used in the goal and objective, which helps to align the quality improvement tool with the state's overall behavioral health quality improvement goals. Slide 40, please. As Malia mentioned regarding LTSS quality improvement, states can customize their D-SNP's involvement in behavioral health Medicaid quality improvement tools based on the D-SNP's level of integration. In the case of a coordination-only D-SNP that does not cover Medicaid behavioral health services, the D-SNP would only be involved in a PIP if the PIP focuses on behavioral health services where the D-SNP is the primary payer, such as inpatient psychiatric services. In the case of a high D-SNP, the D-SNP may be responsible for the coverage of Medicaid behavioral health services. If the high D-SNP covers behavioral health services and the SNP or its affiliated Medicaid managed care plan would implement the PIP. Finally, in the case of a FIDE SNP, the D-SNP is responsible for the coverage of Medicaid behavioral health services and would implement the PIP. Slide 41, please. This slide shows a behavioral health PIP used in Massachusetts that aims to improve care coordination and planning following behavioral health hospital discharge. This PIP uses three interventions, including enrollee support following hospitalization, collaboration among inpatient and acute care facilities, and a care navigator program. States interested in seeing more examples of how Massachusetts integrated D-SNPs into Medicaid QAPI activities can review the Massachusetts EQR report for its One Care program, which is linked at the bottom of this slide. Slide 42, please. Like Malia described for LTSS quality improvement earlier, states can also leverage Medicare quality improvement tools via their SMACs to progress towards their behavioral health quality improvement goals and objectives. For example, the Chronic Care Improvement Program on this slide aims to improve follow-up after hospitalization for enrollees with major depression or schizophrenia. The CCIP's intervention include enrollee support post-hospitalization, collaboration with inpatient and outpatient facilities, and a care navigator program at hospitals, all of which are aimed at increasing follow-up and reducing the risk of readmissions. Like the measure we identified for our behavioral health goal and objective earlier, this chronic care improvement program uses the follow-up after hospitalization for mental illness as its performance measure. Slide 43, please. We have now reached step 4. After implementing Medicaid and Medicare quality improvement tools, states should evaluate statewide progress towards their behavioral health goals and objectives. In this first example, prior to implementing interventions to improve follow-up after hospitalization for mental illness, the statewide baseline rate on this measure was 29%. After implementing quality improvement tools, the state improved its performance on this measure to 34%, but the rate was below the statewide objective of 36%, leaving room for continued improvement. States can use this or a similar approach to evaluate progress towards their goals. Additionally, states can evaluate planned progress towards meeting the state's goals and objectives. Similar to the statewide performance example, in this example, D-SNP-A improved its performance and exceeded its performance target. D-SNP-B also improved its performance but did not meet its target. States can use these results to inform intervention updates as needed to help improve performance. Slide 44, please. This slide describes an example evaluation of Massachusetts behavioral health PIP that I described earlier. This PIP focused on increasing the number of follow-up appointments following discharge, and the state used the HEDIS measure, follow-up after hospitalization for mental illness, to evaluate the PIP. As shown on the table on the right, plan performance on this measure increased from a 49% baseline rate to 54% after the implementation of the PIP, indicating a positive performance change. Slide 45, please. Thank you for attending our presentation, and now we will open it up for questions. Slide 46, please.
Thank you very much, Emily. And thank you also to Maddie, Malia, and Elizabeth for your presentation today. My name for everybody on the line is Ryan Stringer, and I am with the Integrated Care Resource Center. And as Emily described, what we'll do now is open it up for questions, which we're excited to get started. And to ask questions, what you can do is we ask you to submit those through the Q&A icon rather than the chat. And on my screen, that Q&A icon is over on the bottom right-hand side of the screen. We've already had a couple questions come in, so we can jump right off in answering those. And the first one that we saw come in has to do with LTSS and assessing enrollee interaction. I think, Malia, I'm going to see if you have any thoughts on this one. The question, I'm just going to read it here, is my state is just starting to think about how to integrate LTSS benefits that our D-SNPs provide into our Medicaid managed care quality strategy. Which measures do you recommend we review for assessing enrollee interaction with LTSS providers? Any thoughts there?
Yeah, thank you for that question. The CAP survey has several measures related to interactions with providers. For example, the survey includes questions that assess how well staff explain things in a way that is easy to understand, or whether staff know what kind of help enrollees need. So just like we explained earlier, the state could begin reviewing CAPS data to identify quality improvement opportunities, set goals and objectives, and develop quality improvement tools. Some of the foundational resources we went over earlier in our slide deck today are a good place to start when thinking of identifying measures.
Great. Thank you, Malia. And I'm just thinking out loud, Malia, you mentioned some of the foundational measures. The first one I'm thinking of foundational resources. The first one I'm thinking of is our ICRC quality oversight and improvement tip sheet, which we released back in late 2023. We followed that up with a webinar shortly thereafter, and those are both posted on the ICRC resource. So check those out. And then the other thing I'm thinking of in terms of resources are, we haven't gotten there in the deck, and we're not going to go to the slides or anything like that, but you'll see in this slide deck, when it's posted on the ICRC website, and we've released it as well, is that we've got a big appendix with lots of different measures, and they're sorted by topic area, like LTSS, which we went over in the slide deck, and behavioral health, which we went over in the slide deck as well. Lots of different measures from different measure sets that you can review there, from things like HCBS caps, the Medicaid LTSS measures, both for fee-for-service and managed care LTSS, adult core set measures, HEDIS measures, SNP HEDIS measures, et cetera. So there's a big appendix right at the end of this slide deck, which has got lots of measures for you to consider when you're thinking about how are we going to start developing and identifying quality improvement opportunities, then developing goals and objectives, and so on, like we described earlier in the slide deck. So thank you very much, Malia, for your pointers there. We had another question come through the Q&A function on the webinar. Aaron, I think we've got you on the line. I want to tag you on this one, and I'm going to read it out loud. The question is, if a state were to compare to another state on measures, for example, HEDIS measures, LTSS measures, what have you, would it be best to make sure it's a one-to-one comparison. For example, each state here, is it true that each state would need to have D-SNP only contracts in order to make a comparison accurately? And then as a follow-up, would a comparison at a national level have similar issues when comparing across states? And Aaron, I want to see if you have any thoughts there. And if not, we can always invite the individual who asked the question to email ICRC and we can look into it as well.
Yeah, I'm happy to weigh in on that one, Ryan. Thanks. So the short answer is that certainly in an ideal world, when we're comparing results on any kind of measure, it would be wonderful, right? And absolutely ideal if we could always make comparisons between what we often say are apples and apples, right? And have as many similarities as possible between what we're comparing. Unfortunately, in the real world, we don't always have that ability, right? We may not, if your state is an apple, you may be surrounded by watermelons and you may not have the opportunity for that apples to apples comparison. And I would argue that there often are ways that you can compare data across plans and or across states even if you don't have an apples to apples comparison situation, and you can still make use of that information, of those comparisons that you are able to do. So the point that the question asker makes, for example, about would both of these states have to have those D-SNP only contracts to be absolutely certain that if they're looking at a contract level measure, that the only entities that are involved are D-SNPs. Again, if in an ideal world, that would be great. So if you are a state that has D-SNP only contracts and you are trying to make a comparison, the gold star best way to make that comparison would be to try to look at data from another state that also has D-SNP only contracts. That doesn't mean, though, that if that doesn't exist and you don't have the ability to make that apples to apples comparison, that you can't do it. I think the point is a very good one, that it's useful to try to consider the contextual factors involved and to try to find plans or states that can be compared to one another as best as possible. But it doesn't have to be perfect. You don't always have to have a perfect comparison. And I would also argue that the vast majority of the states in the US right now don't have D-SNP only contracts. And so if you're one of those states where your D-SNPs are inside of a contract with other kinds of Medicare Advantage plans, maybe plans in other states, right? And you have this very imperfect picture of the measures anyway, it doesn't mean you should just throw up your hands and not look at any quality measures, right? It means you should be thoughtful about what might be most meaningful to you in that context and with your specific goals in mind. But you can still use quality measures and you can still make comparisons, especially across the many other multitudes of states that don't have D-SNP only contracts either. And so to the layer in there about what about national level comparisons, like wouldn't that have issues too? I would argue that the national level comparisons can actually be a great way to sort of blend together all of the variants and all of the different contextual factors that arise across a multitude of states. And so in some cases, it can actually even be better to compare, measures and results in your state to a national average across states. That can be a way of sort of washing out some of the challenges that might arise if you're doing an apples to oranges comparison from one state to another state. I could probably talk about this for hours. I will also make a strong recommendation that ICRC and MMCO are happy to engage with states on these topics in our opportunities for one-on-one technical assistance as well. So please feel free to reach out to us through our ICRC email box to request that kind of technical assistance if you would like some of our experts to engage with your state in particular about the goals that you have, the things you're trying to achieve, and ways that you might, first of all, be able to measure progress on those goals, and also what might be the most readily available and appropriate comparisons for you in your particular state context.
Great. Thank you so much, Erin. We've got another question that came in here as well. And that question is, how would you recommend incentivizing plans to meet performance improvement targets if that is not a formal performance improvement project with financial incentives? So I'm going to speak to this and I can take this question. I think I'm going to speak to this from the Medicaid payment side, right? Because if this is a D-SNP that is receiving capitated payments from the state to cover things like Medicaid LTSS, Medicaid behavioral health, transportation, dental, et cetera, the state's going to go through the rate setting process, et cetera, to pay that D-SNP to provide those benefits. Or let's say you've got a D-SNP with an affiliated Medicaid managed care plan that's covering those LTSS or behavioral health services. That affiliated Medicaid managed care plan, the state can apply certain financial incentives on that plan. And I think the gold standard here is if you're trying to move the needle in terms of quality improvement, performance improvement, et cetera, you've got a lot of tools, but I'd really encourage you to start and think about the power of the purse on the Medicaid side. Because like I mentioned, you're going to be going through the rate setting process. You've got a lot of tools there. You've got capitation withholds, which is going to allow you to withhold a certain percent of capitation payments paid out to plans on the Medicaid side, pending plans meeting performance targets. You've also got performance incentives or bonuses. I've seen bonus pools, things of that nature. There's also, I think I've seen another state use something called a gain sharing arrangement or a profit cap on the Medicaid side, which allows the state to pull back a certain amount of profit that goes over a certain threshold. For example, if on the Medicaid side, a plan has a 10% profit margin, the state can claw some of that back, works a little bit like MLR or a risk corridor. And those gain sharing arrangements allow plans to retain a bit more profit over a certain threshold for meeting performance targets. So there's 3 tools right off the bat there that you can use in terms of the power of the purse on the Medicaid side to incentivize strong performance. If financial tools, those types of incentives like the carrots aren't really an option for you on the state side, maybe it's a policy decision, something like that, Medicaid plans that provide Medicaid services, they're going to go through a procurement process on the Medicaid side and think about your procurement rules, what they allow you to do within your state. They're all different. Think about your procurement rules because you can reward the plans that are providing really strong performance on particular quality measures, et cetera, with more points when you're figuring out which Medicaid plans you want to contract with. And we've got a tip sheet on the ICRC website, which explains a lot about this, how to think about procurement and rewarding the plans that are providing the highest quality and value for you and for dually eligible individuals. And of course, I also have to mention, this isn't a financial incentive, but you can consider sticks. So you can consider fines for poor performance. We've seen that. And perhaps for particularly, let's say, egregious or ongoing, particularly poor performance, you can look at sanctions. You've got sanction authority under Part 438 for the Medicaid side as well. So you've got a lot of tools on the incentive side. Sort of think about those as carrots, and you've got a lot of tools on the stick side, thinking about fines, sanctions, et cetera, if you're seeing particularly poor performance that you want to correct over time. So those are a few ideas that we had there as well.
And thanks, Ryan. This is Erin. I want to jump in on this too and just offer a couple of additional non-financial ideas that we've seen in some states, particularly for those of you that you might have a state where all you have is coordination only D-SNPs. Maybe you don't have Medicaid managed care on the Medicaid side, so you're some of those that Medicaid power of the purse that Ryan talked about might not be applicable in your situation. We have seen states use things like procurement, contracting, and enrollment related things as carrots and sticks as well. So for example, we've seen a state that said that they will only let certain D-SNPs do default enrollment. That is something that's only applicable if you do have Medicaid managed care, but the state said that they will only let D-SNPs do default enrollment if the D-SNPs meet this particular requirement that the state has, this particular performance related threshold, right? So default enrollment can be a carrot. Other marketing requirements can become a carrot or a stick. You can't have marketing requirements that conflict with the CMS marketing requirements, but you can actually layer additional requirements into your D-SNP contracts about what is not allowed or is allowed in terms of D-SNP marketing. And then you can set that up to be a carrot, right? That D-SNPs are only allowed to take XYZ marketing steps if they have met your quality or performance improvement thresholds. We've seen states that on the penalty side will say that the D-SNP will have to pause enrollment if they don't get if they don't achieve the threshold that the state sets. So they would have to not take in any new enrollees if the state tells them that they have to stop enrolling people because they've missed that target. And you can always use the threat of we will not contract with plans in future years if you don't meet these particular requirements. So there are things that you can do even if you're not directly paying these plans that can actually function as incentives and penalties in this regard as well.
That's great. Thank you so much, Aaron. So to sum all that up, you've got a variety of financial incentives, you've got procurement tools, you've got civil monetary penalties, you've got enrollment tools, you got marketing tools. So there's a big litany of various tools that you can use in your state, depending on what you've got to incentivize improved quality and performance. So if you want to learn more about that, I'm sure we'd love to talk about it. And if you are, we can schedule a TA call if you'd like. Just looking at the clock here, we've had a great webinar, and thank you so much, everybody, for your questions. And now what I'm going to do is I'm going to hand it back to Emily to wrap things up today. So slide 47, please.
Thanks, Ryan. Thank you, everyone, for participating in today's webinar, and thanks once again to all of our presenters. A couple notes at the end. If you would like to revisit today's conversation and the slides, a recording of the call and the presentation will be uploaded to the ICRC website. I urge you all to visit the website where you can find links to past webinars, briefs, and you can also submit TA requests. And we hope this has been valuable for all of you today. If you are logged into Zoom, please complete the survey that will appear at the end of the webinar. We are looking forward to reviewing your feedback and making any changes to future webinars. The survey will also be sent out through email with the recording and slides after the webinar. Thank you.